just, and last night, the slide is posted, the spontaneous force of contraction, generate that muscle. Moved it here just because we're going to start with ECGs. We were looking at contraction of the heart, right? How the heart contracts, the atria and the ventricles contract, and we have that systole and diastole generating the pressure that it's the driving force, right? So that hydrostatic pressure of the blood exerting a force against the walls of the blood vessels. And the contraction of the heart chambers are going to generate that driving force, which we call blood pressure. To generate that muscle contraction, you need a muscle action potential. And the muscle action potential in the heart comes from pacemaker cells that are cells within the heart. So they are cardiac cells as well. So you have pacemaker cells and you have cardiac muscle cells. Those two make the heart. The pacemaker cells or nodal cells or autorhythmic cells, however you want to call them, they don't generate a force of contraction. They don't have sarcomeres. They're too small and they're too few. Only 1% of your heart is made of those pacemaker cells. But they have the important role of initiating that depolarization. They spontaneously depolarize, and that action potential moves to cardiac muscle cells or myocardial cells through gap junctions. And we looked at the electrical conduction system of the heart last class and how that signal is initiated at the SA node, then moves through those internodal pathways, those highways, and also through the streets to the cardiac muscle in the atria, get to the AV node. The only way it can go from atria to ventricles is through the AV node. Then you have the bundle of His that branches into left and right bundle of His. And you have then the Purkinje fibers. And that brings the signal really quickly to the bottom of the heart, so we depolarize and contract from the bottom to the top. Now, we can measure the electrical activity of the heart. We cannot measure the electrical activity of the heart easily from the pacemaker cells, which are really the original cells generating that action potential. But we can very easily generate that or record that electrical signal of the heart from the activity of cardiac contractile cells using an electrocardiogram, which you abbreviate ECG or EKG because it was figured out by a German scientist back in the day. So electrocardiogram, and how many of you have had an ECG at the doctor's office? None of you? No? That's very healthy population here. Well, you go to the doctor's office, they do the auscultation where they put the stethoscope and they listen to the heart sounds. They listen also to the lung sounds. They measure your blood pressure and all that. But they also sometimes, if they're suspecting a problem with the heart, the next step, which is very easy non-invasive, it's an ECG. So they're going to put a number of electrodes on your chest, an electrode here, and on your left leg, on the left ankle. And they, with the standardized placement of these electrodes, and they just sit on your skin. They put a gel that conducts, and they just put them in your skin, on your skin. They don't poke you or anything like that. They can measure the electrical activity of the heart, that action potential, but it's the sum of action potential. It's not one action potential, because for measuring one action potential, you would need to actually poke the cell and measure intracellularly, right? But it's the sum of that depolarization event happening at a moment in time of all those cardiac muscle cells. We cannot measure it from the pacemaker cells because they're too few and too tiny. So to pick up that signal, right, extracellularly with pads on your wrists and your chest is going to be too hard. But because the muscle of the heart, we have so many of those muscle cells, right, it's bulky. All of them depolarize at the same time, you're going to be able to pick up that signal in those, on those pads, and that goes to a machine that integrates that signal. You learn that in Human Physiology 1, how it's done, and you end up with an ECG. This is the textbook ECG. Not all the leads give you that ECG, and it varies between people, right? Because the heart, it depends also on the position of the heart. So your heart, for most people, is going to be the bottom of the heart pointing to the left, right? And sitting on the left side of your chest. Some people actually have it on the right, and their ECG will look different. Very few, but some people have it. So what do you have here? You have the time in milliseconds on the x-axis, and the millivolts, the membrane potential, that depolarization event and repolarization event of a bulk of cardiac cells, not one, but a bulk of them on the y-axis. So this is in millivolts. And remember, it's the extracellular recording of the electrical activity of cardiac contractile cells. You cannot measure the pacemaker cell contraction from outside your body. They're too few, too tiny. But that action potential in the pacemaker cell transfers to cardiac muscle cells, so you can correlate them. Okay, so as you see here, we have a number of deflections, like this one, like these ones, this one, this one. Those are called waves. Okay, waves. You have these baselines here, which are called segments. Okay? And then you have a combination of waves and segments, and you grouped calling them intervals. Okay? I'm going to teach you the very basic of the ECG, because you should be able to learn this in Human Phys 1. Okay? Hopefully they teach you this in Human Phys 1. So I'm going to give you the very basics, because this is introduction to physiology. So here we have, but let me go back here. So what the technicians actually do, and the cardiologists, is they look at the width of these deflections, at the length of these segments, at the length of these intervals, and they get that in milliseconds. So they know what the normal duration of the P wave, for example, is. If it's too long, then something is going on with the atria, with the cardiac contractile cells of the atria or the SA node. If this PR segment is too long, the signal is too delayed in the AV node. If it's too short, it's going too fast through the AV node, or maybe it's bypassing the AV node. So you can't tell a lot from an ECG, and that's the first thing doctors do. They do an ECG, and then if they see something wrong, then they do further tests. So let's look at the steps of the ECG. So I'm showing you in yellow the depolarization event, basically that action potential. Remember, the action potential is initiated in the SA node. That's the pacemaker of the heart, the SA node. So because it has the fastest depolarization rate, right? And depolarizes spontaneously. So you initiate that action potential there, and it starts traveling through gap junctions onto those cardiac muscle cells of the atria, and really quickly through the Beckman bundle here, and transfers to the cardiac muscle cells of the left atrium. So right and left atrium start depolarizing, and that's what you measure here with the P wave. So the P wave is atrial muscle cells depolarization. So the muscle cells of the left and right atria depolarizing, having that action potential. Okay? Then you get here to this PR segment, which I show you right here. That PR segment, do we have a depolarization or repolarization? Do we have anything like that in the PR segment? What's going on? Are we changing the millivolts? Are we? Millivolts stay the same, right? It's a baseline. So the electrical activity is not changing. That doesn't mean something is not going on. What's going on in the PR segment is the signal is stuck in the AV node. So the signal, remember, is delayed sometime in the AV node, and that's what you're seeing here in the PR segment. No change in electrical activity because the action potential is there. It hasn't moved forward. Okay? And remember, the depolarization or that action potential cannot move from the atrial myocardial cells to the ventricular myocardial cells because we have that connective tissue separating the atria and the ventricles. So they're not connected by gap junctions. After the PR segment means that the signal is going to, once it manages to get out of the AV node, okay, it moves onto the bundle of His. And the bundle of His is going to move, remember it's big cells, so they're going to move that signal, conduct that signal very quickly to the bottom of the heart. We call that the apex of the heart. The bottom of the heart is called the apex. So it moves that signal, that action potential, very quickly down here. However, you guys remember I told you that the ventricles, left and right ventricles in mammals, as humans being mammals, is completely separated. Is separated by the ventricular muscle ridge. So basically, a stiff muscle that separates the left and right ventricles. Okay? And when the signal, the action potential, is moving really quickly right here, it is going to depolarize actually some of those sodium ions, that positive charge, that depolarization is going to move to septal cells. The septum, the ventricular septum, is muscle, is made of muscle. And they depolarize, but they're not a chamber, it's a septum, a muscle ridge. Okay? So what happens is it stiffens a little bit. That's the contraction it has. Okay? But to contract, it needs to depolarize. That depolarization, even though it's moving very quickly down to the bottom, and we don't have the ventricular myocardial cells really depolarizing yet, this one's the septal cells stiff here, and that's what you see here with this deflection, which we call that the Q wave. So let me show you. This Q wave here is that the septal cells over here near the bundle of His depolarizing. Okay? So you don't always have a Q wave. Okay? Then we have the bulk of the depolarization, so the bulk of the action potential, and that's going to be the R over here. So that's that signal going down here and starting to depolarize the ventricular cardiac muscle cells, and you get this positive deflection called the R wave. You almost always have an R wave. And then you have the signal going into these Purkinje fibers, deep in the muscle, and that's going to be that S wave. So these other little negative deflection here, that's an S wave. These are all depolarizations because it's extracellular. So don't think that's a repolarization. It is not. Positive in this doesn't mean depolarization, negative repolarization, because we're looking at extracellular recording, okay? So far I've shown you the P wave, the Q, the R, the S. All those are muscle cells depolarizing, okay? Now, at this point, we go into this other baseline here called the ST segment. And this ST segment is when all of the ventricle muscle cells are depolarized, and they stay depolarized for a little bit. You learn why later on. It's something called the calcium plateau. You learn that in Human Phys 1, why that happens when you look at the specific action potentials here. But that's basically no change in electrical activity. And then you have the T wave. And the T wave is repolarization of the ventricular muscle cells. It's positive, but it's a repolarization. They're repolarizing. Again, why this happens and is positive, you can learn that in Human Phys 1. All right. One thing that I want to point out here, or want to ask you actually first, is why am I not seeing the atrial muscle cells repolarizing? Are they not repolarizing? I'm showing you the T wave here, that is the ventricular muscle cells repolarizing. The atrial muscle cells must have repolarized, right? Otherwise, we cannot go again on another action potential. What do you think is going on? Why cannot we see a wave or an inflection indicating the repolarization of the atrial muscle cells? We see the depolarization, and shortly after, we should have the repolarization. What do you think is going on? Just a wild guess. What do you think is going on? It's simpler than you think. Yeah. So there is a refractory period, absolute and relative, like in the neurons and in the skeletal muscle cell. But they are repolarizing. It's just that the QRS complex is so big, it masks it. So if you were to block the signal from going through the AV node onto these ventricles, you wouldn't have a QRS, but you would see the repolarization of the atria, because it happens at this time right here, but it gets covered, masked by that QRS. Does that make sense? All right. The other thing that I want to point out is that the mechanical events occur a little bit after the electrical events. Okay, so even though you cannot measure the muscle tension or the muscle contraction, that pressure generated when the ventricular muscles or the atrial muscles contract when they're in systole, you can still correlate it, because remember, for that muscle contraction to occur, a muscle action potential must have happened before that. Okay, and for the muscle to relax, the repolarization of that muscle must have happened. And that's what you're seeing here, depolarization and repolarization of that muscle. So you can correlate the mechanical events. They happen just a little bit after the electrical event. Okay, and we'll look at that in just a minute. The last thing I want to talk about in this thing before I review this topic and move on to blood pressure is that cardiac output, it's a measure of how effective the heart is working as a pump. It's not telling you where exactly that blood is being distributed. So if you ate a big meal, it's going to be mostly going to the GI tract. If you're running a marathon, mostly going to your skeletal muscles. If you're taking a test, mostly going to your brain. But cardiac output doesn't tell you where it's going. That's going to be determined by the arterioles contracting or relaxing that smooth muscle and distributing the blood to different capillaries. But the cardiac output indicates the volume of blood pumped by each ventricle per minute. Okay? So it's going to depend on the heart rate and the stroke volume. So how fast the heart is contracting, that's beats per minute. So for example, 60 beats per minute, multiplied by the stroke volume. The stroke volume is the volume of blood ejected by each ventricle in one cardiac cycle. So normally each ventricle pumps 5,000 milliliters of blood per minute, or 5 liters of blood per minute, each ventricle. Okay? So let's go to our clicker questions. So here we have the code is 65. What electrical event, it's not working. Oh, okay. Okay, what electrical event in the ECG will be lost if the SA node is damaged? What do you guys think? If the SA node is damaged, remember the SA node is at the top corner of the right ventricle, and it's the pacemaker of the heart. If the SA node is damaged, we still have the AV node and bundle of His that can depolarize spontaneously and initiate that muscle action potential and contraction. It'll be slower and not great, but it'll keep you alive until you get a doctor. Okay? But what event in the ECG you wouldn't see if that SA node is not firing action potentials? P wave, how many hands? Okay. QRS? T wave? None? Okay. See, you guys knew it, P wave. Why? Because the P wave, the SA node depolarizes. Even though in the ECG we're not measuring the depolarization of the SA node or AV node or bundle of His or Purkinje fibers, this depolarization is going to start spreading to atrial contractile cells. So if the SA node does its damage, the event that would be lost right there is going to be the P wave, because this depolarization won't be initiated and you won't have that depolarization of the cardiac contractile cells of the atria. Which pacemaker cells set the heart rate? Which is the pacemaker of the heart? Somebody just said it. SA node, right? Okay. What mechanical event is associated with the QRS complex? So the QRS complex is what? What is the QRS complex showing you? What cells are depolarizing? Ventricular cardiac contractile cells are depolarizing. A muscle action potential is going, it's happening. The depolarization phase of the muscle action potential. But here I'm asking you about the mechanical event associated with it. So remember, the QRS is millivolts, right? It's an electrical event. But right after that ventricular depolarization of cardiac muscle cells, we get contraction of those ventricular cells. So ventricular contraction. So if you look here, you have first the atrial depolarization, right? So the P wave here is atrial depolarization. A little bit after the atria depolarize, you get the contraction of those atrial muscle cells, so atrial systole. And that happens during this PR segment. So remember, in the PR segment, the signal is stuck in the AV node. No electrical activity is occurring, but actually the atria are contracting. Left and right atria are contracting and having that active ventricular filling phase, actively pushing that 30% of the blood, remaining 30% of the blood into the ventricles. Then you have here ventricular, the QRS is ventricular depolarization. So the cardiac muscle cells of the ventricles, both left and right, are depolarizing. And a little bit after, you see this baseline here, which we call the ST segment. This baseline here, no electrical activity is happening. All the cells I told you are depolarized in the ventricles. The muscle cells of the ventricles are depolarized. But at that time, in that ST segment, we're having ventricular contraction. So the left and right ventricle are contracting. We start ventricular systole, and they are going to actively eject blood, the right ventricle onto the pulmonary arteries, the left ventricle onto the aorta. Okay? Then we have ventricular repolarization here. So the muscle cells of the ventricles repolarize that T wave. And after this baseline here is ventricular relaxation. Even though you cannot measure those tension or force of contraction or pressure events with the ECG, you can correlate it because they happen a little bit after that electrical event. The mechanical event, which is contraction and relaxation, happens a little bit after the electrical event, which is depolarization, repolarization. All right. I'm going to ask you to calculate the cardiac output of a person that has a heart rate of 10 beats per minute and a stroke volume of 500 mils per beat. And I want to point out, it's not just 500 mils. It's 500 mils per beat per cardiac cycle. Because right now you can have 500 mils per beat being your stroke volume. But if you have to run for your life because this catches fire, that's going to go up to 600 mils per beat. So in your next cardiac cycle, you're going to pump more blood. Does that make sense? Okay, so how would you calculate this cardiac output? What would you do? Does anybody want to give it a try? What's that? Multiply them. Multiply them. So you're going to multiply 10 beats per minute times 500 mils per beat. Cardiac output is heart rate times stroke volume, so you multiply them, you get 5,000, right? Remember, units are important, so you're going to cancel beats, and you end up with mils per minute. Okay, make sure you include the units. That's it. That's why if you only do 500 mils, you won't get the correct units either. Okay, so always look at the units. Units sometimes gives you the answer. Any questions about the ECG before I move on? No? Okay, I'm moving on then. All right, we're going to look now at blood flow patterns and blood pressure. And we've already discussed the types of blood vessels, right? We looked at the aorta and the arteries, saying those are the blood vessels that do that elastic recoil. So you see here we have the tunica externa, which is that outer layer that has elastic fibers, okay, so proteins that are elastic. We have the middle layer, which is smooth muscle, and we have the inner layer, and that's the tunica media. And the inner layer here in blue is the tunica intima, which is just one layer of endothelial cells that are in contact with the blood that would be here flowing through the lumen of that blood vessel. So arteries and aorta have a lot of that tunica externa or elastic protein. So they do this elastic recoil. It takes quite a bit of force to expand them, but we store that potential energy on the walls of that artery. When you let go, when the ventricle stops contracting, when it goes into diastole, the blood vessel just goes back to its original position like a rubber band, and that causes forward blood flow. Okay? Arterioles are the resistance blood vessels because they have very little elastin, but they do have a ton of smooth muscle. So they still have that tunica intima here in purple, which is that the endothelial cells lining the lumen of the blood vessel, but then they have a ton of smooth muscle. So these ones are the ones that vasoconstrict or vasodilate really quickly. So if they vasoconstrict, they decrease the radius of that blood vessel, less blood flow. If vasodilate, they increase the radius of that lumen of that blood vessel, more blood flow. So they're going to determine the distribution of blood to the different tissue capillaries. The capillaries are the exchange blood vessels. Remember, they don't have any elastin fibers. They don't have any smooth muscle. They're just made of the tunica intima, and only one cell layer thick, so that we can exchange materials like oxygen, CO2, hormones, nutrients, metabolites, etc., through the walls of those capillaries. Makes diffusion happen effectively. And so far, we've gone from one aorta to several arteries to hundreds of arterioles to thousands, 100,000 capillaries. So it's a divergent pattern. But now we're going to start going back to fewer blood vessels. So we go from hundreds of thousands of capillaries to hundreds, or I should say thousands of venules, which venules are going to start having that smooth muscle in the larger venules, and then you move to some veins, and then the veins are going to empty in the superior and inferior vena cava that send the blood to the right atrium. Okay? The veins are similar to the arteries, but the walls of the veins are thinner. Okay? And they are more superficial. They're placed, so the ones you see on your arms, those are going to be veins. The arteries are deeper. All right, here I'm showing you a very important concept that I need you guys to understand. So I'm showing you here the aorta, and here's aorta, diverging into some arteries. Here I have arteries. Those diverge into some arterioles. Then we have the capillaries, and you see capillaries here. Then we have the venules, veins, and the vena cava. Okay, it's really superior and inferior vena cava, but they put it here as one. So you have this divergent and then convergent pattern. Now here I have the blood vessels and the diameter in millimeters of each blood vessel. So the diameter would be measured. If you had the blood vessel here, I cut it in half. You measure from this point to this point. So from this point to this point. Okay? And we're going to calculate the cross-sectional area of each blood vessel. So again, cross-sectional areas, if you cut it like this and you take the area of the circumference. And then you add it up. So for the aorta would be just that one, but if you're looking at capillaries, you add up the cross-sectional area of 100,000 capillaries that you have there, okay? And here you can plot the area of the different blood vessels. So you see that, that even though the aorta is the biggest blood vessel, okay? I mean, no, the biggest is the vena cava, but second biggest blood vessel, so 25 millimeter diameter. So from here to here is 25 millimeters. So it's pretty big, okay? It's only one. So the cross-sectional area is only going to be 2.5 square centimeters. And that's what you're seeing right here, okay? As you move through to arteries, arterioles, and capillaries, you see that the cross-sectional area starts increasing. Even though each individual artery is only 4 millimeters in diameter, you have a ton of them. So if you add, let me draw down here, draw this with my pen. If you measure the cross-sectional area of all these arteries, so you're measuring cross-sectional area of all these arteries, and you sum them, you get a bigger cross-sectional area than that for the aorta, which was only one. And then if you do that, for example, for the capillaries, even though each of them is tiny, you have hundreds of thousands of them. So you sum that up, you sum the cross-sectional areas, and that's going to be the largest cross-sectional area is going to be in the capillaries. And then it starts decreasing as you go from venous veins to the vena cava. Now, why am I telling you this? Why is cross-sectional area important? Because it's going to affect how fast blood moves. So we talked about blood flow before. Okay? And blood flow is going to be the volume of blood that moves per minute. We call it Q, blood flow. It's a rate, right? It's the volume of blood moving per minute. But if you maintain the same blood flow, and I'm going to erase this so I can show you here. If you maintain the same blood flow, the velocity of, but change the cross-sectional area, the velocity of blood flow is going to change. Because the velocity of blood flow is going to be, this is velocity, I should put it like this, the blood flow over the area. So if blood flow is maintained the same, but you see here the area increases, you're dividing by a larger number, then velocity in the capillaries is going to be lower than in the aorta. So blood flow. Blood flow is if I look at how many people move past that door, okay? So the number of people that go passing by that door per minute, that's going to be my blood flow. But how fast a set number of people, let's say 10 people, move from across that door, that's the velocity of blood flow. So see the difference? One is the amount of people in 1 minute moving past by. Okay? And the velocity of blood flow is a given number of people, how fast they move across that door. So velocity of blood flow is going to be affected by the cross-sectional area. And why is that important functionally? Well, what happens in the capillaries? In the capillaries, we have exchange. We have diffusion happening, right? So I'm bringing arterial blood, right? And I get here to the brain, and I need to deliver the oxygen and the nutrients, pick up the waste and the CO2, and keep going, right? If I move too quickly, am I going to be able to drop everything and satisfy the demands of that tissue? Probably not, right? I need to go not too slow, because I need to maintain the gradients, but at a certain velocity that gives me enough time for oxygen to diffuse, CO2 to diffuse, nutrients to diffuse, waste to diffuse. Does that make sense? So that's why velocity of blood flow or velocity of blood is lower in the capillaries because it needs to give time for that exchange or diffusion to occur. Now, the other thing that I want to talk about now, it's going to be this pressure graph. And I'm going to move to the next slide here. So pressure, blood pressure, right, is going to be that driving force causing the flow of blood. Pressure, as you see, it's higher at the level of the aorta and nearly zero at the level of the vena cava. So coming out of the heart in the aorta, remember, left ventricle pumps that blood into the aorta. The pressure generated is high. Why? Because the ventricle is right there. So the left ventricle contracting very forcefully, pushing that blood into the aorta very forcefully, that's going to generate a big blood pressure in the aorta. But as we move through the circulatory system, so from the aorta to arteries, to arterioles, capillaries, and so on, that blood flow, the pressure of the blood is going to decrease, and it's pressure in millimeters of mercury. Okay? Why is it decreasing? It is decreasing because there's resistance to blood flow. So blood is a fluid, and it's going to go through those blood vessels, through the lumen of those blood vessels. Well, the wall of the blood vessel is going to generate friction, right? And that's going to slow down blood flow until that driving force disappears. It's like a bowling ball, right? If you throw a bowling ball, it's going to go. And at the beginning, it's going to go fine, and eventually, at some point, it's going to stop. Why would it stop? I mean, in a perfect system, inertia, right? One of the physics law says that it'll keep moving until something stops it. Well, what's going to slow it down and eventually stop it is resistance, right? It's that friction that it's going to encounter with the surface of the ball with the ground, with the floor. Same idea here, that fluid is going to encounter friction and resistance produced by that blood vessel wall. So by the time you get to the capillaries, the pressure is already very low. At the level of the vena cava, it's practically 0 millimeters of mercury. So my question to you guys, what causes then that blood to return to the heart? If the pressure, which is the driving force, decreases significantly, look, by the level of the capillaries is 20 millimeters of mercury. At the level of the aorta was around 100 millimeters of mercury. What makes it keep going? And then you have gravity, right? You have to move some of that up towards the heart. So I want you to think about it. And in the next slide, before the next slide, we'll answer it. Okay? Not in the next slide, in 2 slides. Okay. So what other characteristic I want to show you here in this graph, not only that pressure decreases and is practically 0 before it returns to right before it returns to the heart, but also you see that in the arterial systemic circulation, so aorta, arteries, and arterioles before the capillaries, you see these oscillations. And you don't see these oscillations in the venous systemic circulation. Why do you think these oscillations happen? And it's written right here. What's causing those oscillations? What do you guys think? Yeah. Those are the systolic and diastolic blood pressures, right? And they're caused by ventricular systole and ventricular diastole. So when the ventricle contracts, we're going to forcefully push that blood, and you get that peak over here, which is going to be, when you measure that in the aorta, is going to be the systolic blood pressure. Okay? It's not the pressure generated by the ventricle, but it is the pressure of that volume of blood that arrived to the aorta forcefully, exerting a force against the walls of that aorta. So it's blood pressure. Okay? It's not ventricular contraction, but it happens due to ventricular contraction. And then you have the diastolic blood pressure. The diastolic blood pressure is the lower peak, and that is when the ventricle is relaxed, when the ventricle is in diastole, not pushing blood into the aorta. That is the hydrostatic pressure, the pressure that blood is exerting in that blood vessel without being forcefully pushed by the ventricle. Okay? So in the arterial circulation, you're going to see those oscillations. And you go to the doctor and they measure that. They put it right here. They really would like to measure the pressure, the blood pressure in the aorta, but they can't, right? So they do it at the same level of the heart and on your arm, which is measuring the blood pressure in the subclavian artery, which is a branch, an immediate branch of the aorta. So right after the aorta branches into coronary artery and subclavian carotid artery. So right here, it's the easiest part, and also it's at the same level of the heart because gravity changes things, right? So that's when you get that 120/80. That is the systolic over the diastolic blood pressure. And then you can average that, and they tell you, okay, you have a mean arterial pressure of 100 millimeters of mercury. That is basically the average between the systolic and diastolic blood pressure. And I'm not doing the math incorrectly. It's 100, even though you have 120 and an 80, because you spend more time in diastole than in systole. So it's 2/3 of the diastolic blood pressure plus 1/3 of the systolic blood pressure. But you don't know, right now you don't need to know that formula. I may ask you to learn it later, but right now you just need to know this is systolic, this is diastolic, and you can average it as the mean arterial pressure. These oscillations are going to decrease, of course, as you move forward because we're going to move further and further away from the heart. And when you get to the capillaries, the blood flow is continuous. So you guys have seen CSI? It was super popular back in the day. CSI, these people would go, it was super fake too. I have a friend, when it became super popular, I had friends from graduate school that decided to become CSI. And then they told me it's super boring. This was in Canada because really nothing happened, And thank goodness nothing happened. You don't want crimes to happen, right? But there was a bunch of them that went into becoming CSIs, and they, criminal science investigators. So these people would go in this TV show, right, and would see a splatter of blood on the wall and would say, that's arterial. How do they know that? Because it'll splash. If you were to cut my carotid artery right here, that's hard because it's deep, but if you were to cut the carotid artery, you would see a splash of blood because it goes systole, diastole, systole, diastole. If you cut my jugular vein, then it'll be like dumping a bucket of blood. Does that make sense? Because it's not pulsatile, all right? That's how they knew. They knew the brand of the car they carried that cadaver in. No. But they at least could tell that. All right, which blood vessel would you use to draw blood from? Just to review here. I already answered this one on Monday, I believe. Veins. Veins, because veins are, first of all, more superficial. Second of all, the walls are thinner, so easier to access, to poke, and you won't have that splatter of blood, that pulsatile blood pressure that you have in the arteries. All right, so I asked you, how do we make blood get back to the heart if the pressure here is nearly 0 millimeters of mercury? Did you guys come up with an answer? Nope. Nobody? It's okay to be wrong. Remember, we learn from mistakes, right? This is a class, you're learning, so you're not supposed to know this. But any guesses? Yeah. The same, so you're along that is great. You're along that line of thought, right? The blood flow coming out from the aorta, arteries, arterioles, capillaries, and so on this is going to keep pushing that blood, even though the pressure is now so low, back to the heart. So that flow, it's a closed circulatory system, and if some blood goes from the left ventricle into the aorta, well, blood needs to then move forward, right? You cannot just accumulate it and accumulate it and accumulate it. Does that make sense? That's the first reason. It's a closed circulatory system, so blood coming into the systemic circulation, it's going to push the blood at the end of the systemic circulation on that venous side back to the heart. But we also have some help from two different systems. So not only that it's a closed circulatory system and blood will keep pushing forward, but the skeletal muscle pump, it's not really a pump, but you have veins. So this is in the venous circulation, not in the arterial. It's systemic circulation, but on the venous side. You have veins that run kind of between the muscles, okay? And veins, they're very thin-walled, so they're very compliant. You can change their shape fairly easy, not like arteries, okay? They also have valves. So these valves prevent backflow. So arteries don't have valves, but the veins do have valves, and they can prevent backflow of blood. So when you move your legs, this especially happens in the legs, the muscle contracts and squeezes the vein. And blood cannot go back because you have the valve, so it can only move forward. And that actually helps return blood to the heart. So you know when people are in bed rest, they come and move their legs. That's not only so that the muscle doesn't atrophy, that is also to return blood to the heart. Otherwise, you start having accumulation of blood that creates a pressure, and it's going to cause leakage of fluid and swelling, which we call edema. In planes, when you have a long flight, you haven't moved too much, some people get the swollen ankles because of that, because the return to the heart is not happening effectively. The last one, the third one, it's going to be the sympathetic nervous system. So the sympathetic nervous system, which is part of the autonomic nervous system, and I'll let you guys go, is going to send a signal, an action potential, and cause smooth muscle of veins to contract. It has an alpha-1 receptor. And that causes the smooth muscle to contract. Same idea. We contract the vein. Blood has to go somewhere. It cannot go back because we have that valve. It can only go up towards the heart. Okay, I'll finish this lecture on Monday, and I will also review assignment 2 and assignment 3, which are included in the midterm. Okay, this is not in the midterm, but the nervous system, assignment 2 and 3. I'll review that on Monday.
Hi, Professor. Sorry, I couldn't make it before 8.